Okay, we're going to get started. I'm Sheldon Schaefer with Hitachi Healthcare Americas, and thank you for coming and joining us for this early morning breakfast session. Hopefully breakfast is good, and I think the speaker is going to be fantastic. Dr. Lawrence Tannenbaum is the Vice President Medical Director of RadNet since 2015 after attending Mount Sinai in New York. Prior to that, he spent 20 years at JFK Medical Center, New Jersey Neuroscience Institute. Dr. Tannenbaum is a senior member of the ASNR and RSNA. He's a past president of the Eastern Society of Neuroradiology and the National CMRS. He's an active educator with interest in advanced imaging and innovative value-adding applications in the spine and the brain. He's authored approximately 100 scholarly and peer-reviewed articles, continues to chair educational and academic meetings, and has delivered over 1,800 invited lectures. Dr. Tannenbaum, I've known for quite a long time. Along with those formal introductions, one I think his key attributes is he is very focused on patient-centric imaging, and that will be a key focal point of his presentation today. So with that, I'd like to introduce Dr. Tannenbaum.
Good morning. I was here last year. Any of you here, any of you catch my presentation I did last year about contrast agents? Yeah, it's really the same, thank you for coming again. You're in for, more of that horrible experience. But my presentation really is in the same vein of, value-driven, challenging some of the things we've done in the past and looking for opportunities to improve care and efficiency. And this talk is clearly sponsored by Hitachi, so we will be really dancing around the open MR issue and really nailing the open MR scanner as a patient-centric strategy before we're done. But there's an awful lot of preamble we're going to go through before we get to that particular point. So I think it's, to have a sense of what my goal is and how it might coincide with your goals and your institutions, I thought it would be worthwhile giving you a couple of minutes as to who we are and what our institution is. It would be helpful if we could get the lights down just a little bit. I don't want everyone to see me sweat in here. But fundamentally, RadNet is the leading provider of freestanding, fixed-site diagnostic imaging services in the U.S. We're largely outpatient, but we do have some hospital affiliations in a number of states. Right now, I believe we're somewhere around 310 owned and operated sites, typically concentrated on the coasts. California, we have a very big presence, as well as the Northeast. But we're also exhibiting at this meeting under our ERAD umbrella, which is an imaging workflow company, and a risk company, a PACS company, and a voice recognition company. So you'll actually see our booth here if you go through the actual session. We have lots of employees, and we've been around for, say, 30 years or so as a publicly traded company. About a year and a half ago, I came to RadNet, with the titles that you heard, with really my responsibility to lead in certain areas, and really I chose to lead in the area of patient-centric and value-driven imaging. My background before that was at Mount Sinai Medical Center, and Mount Sinai is the largest single hospital system in New York City. You can see now it makes up at least 6 institutions, and they continue to expand. But I had the same responsibility, which was the Advanced Imaging Director, MRCT and Advanced Imaging. Now, for those folks who aren't a hospital, who aren't university-based, I spent almost 20 years in the outpatient setting in just a busy community hospital with several imaging centers and a community hospital. I had the same title. Anybody who's from New Jersey? Anybody from New Jersey in here? You might recognize JFK and Muhlenberg Regional Medical Centers. Anybody ever do a site visit with me over the years? Anybody? Okay, you probably came to Edison Imaging Associates, which was a well-known outpatient practice that really specialized in quality and innovation. As a matter of fact, we were once certified at that particular practice as the most efficient MR site in the United States. And those are the actual references that went through how we did it and why we did it. So you have a sense that it's part of my measure of quality, part of my goal in terms of quality is going to be efficiency as well. So, where do we stand today? How do we look at imaging from a management point of view in a different fashion than we have before? And frankly, we're really now focused on managing our patients and focusing on our patients' needs. And we're looking at quality, we're looking at accuracy, and we're looking at value in each individual circumstance. And if you heard the contrast talk, you heard how we challenged the value of screening last year. Anybody who was there will now know that the ACR is now following the same guidelines that we began to integrate about 18 months ago because we didn't see the value in screening before MR contrast agents when we had the right agent in hand. But we'll also look at shorter exam times and the impact it has on patients and how well they receive even a minor difference in scan time, and I'll show you some patient surveys. And of course, any way that we can reduce cost makes our product less costly, as well as gives us an opportunity to function better in this environment. So we look at these types of things in terms of my mission is about quality. We measure quality in a lot of different ways, and part of it is in standardization. In a sense, when you look at a big organization, I hate to say this, but we're kind of making widgets. Okay, we want to be able to knock out an EMR exam in a consistent way from facility to facility, preferably with the same protocol at every site, with an analogous protocol across generations so that we can do that reproducibly, whether it be an IAC MRI or a breast MRI. We want to be able to knock those out consistently. And frankly, efficiency is really, really important. As you know, reimbursements are dropping precipitously, and it's almost all coming off of the technical side. So, that's where the money is going back and forth, and that's where we're getting more and more pinched. So it's really important that we have the efficiency that we need. And frankly, I wouldn't be an imaging specialist here at all if I didn't focus on innovative techniques, innovative machines, innovative pulse sequences that allow us to do things in a better and hopefully more efficient fashion. So again, what our goal is in terms of this big organization is to brand consistency and excellence so that someone will say, hey, this is a RadNet musculoskeletal exam. It's a top-notch exam. It's a RadNet spine exam. These guys know what they're doing. And you know what? As a referring physician, we know what we're going to get. Whether I send to a RadNet site in Brooklyn, RadNet site in Queens, RadNet site in Maryland, we know what we're going to get. And really that is, I think, a big, big factor in terms of what we're after. But again, we're looking at ensuring value in imaging and reporting. That's really one of the things we looked at. So when it comes to efficiency, I think it's important to be operationally optimized. And as you all know, there's a lot of sources of loss of efficiency in an exam, whether it's getting the patient to the on-deck position, getting the patient on and off the table, as well as looking at the way we scan, right? How often, if I were to ask you in your facilities, who thinks that all of their MR sequences across their generations are optimally tuned? And there's no room left for improvement. Well, I certainly don't. Okay, and I've been working on it for 2 years nonstop. So it's a difficult thing. So it's one of the things we're aiming at is some technical optimization. I mean, this is kind of the goal, right? This is a pretty, actually a day-to-day flow sheet from a scanner, a 1.5T closed bore, 60 centimeter bore scanner that I used to operate. If I can see from here, it was running about 26 patients a day, about 31 exams per day. It's not bad, right? Yet the only thing that makes this scanner remarkable is it doesn't benefit from any of the bells and whistles we have today. This is from 1995, okay? And this is the chart of our work at Imaging when we were certified the most efficient site for, in the country. And frankly, there's a lot of things that have to go into being able to do that are throughout the operation. Now, getting back to the things that, when you get to the scanner, the little blind spot, because, we're all administrators, we know how to analyze certain parts of the process. We know what our patient satisfaction is when it comes to scheduling and how well they're treated in the reading room, how nice the technologists are, but there are blind spots that we don't see because we're not looking at the right spot. And one of them is, there's a lot of opportunity to optimize our patient handling around the scanning and workflow of creating a scan. There's a lot of loss that does not contribute to diagnosis at all, okay, that we can manage that will, again, keep us focused on what we're trying to do, which is create a diagnostic exam for the radiologists, for the referring doctors, and the right diagnosis, an actionable diagnosis for the patient. So scanning and workflow, really important. Anybody here MR technologist? Okay, take a look at this slide. This is our localizer and adjustment time on our scanners. You can see that many, many times, I hope I can point with this, which one of these is a pointer? You can see that most of the time our localizer and adjustment time is around a minute, right? That's what you'd expect. But what about these? 5 minutes, 4 minutes, 3 minutes? I'm trying to do 30-minute slots. In a 30-minute slot, I have about 15 minutes to contribute to diagnosis. I have about 5 minutes to handle a patient on, 5 minutes to handle a patient off, 5 more minutes to deal with challenges, to deal with repeat scans, which hopefully you can avoid, and 5 minutes for the technologist to take a deep breath between cases so it's not a stress factory, okay? All right? If I waste them over here doing 5 minutes of localizers, I've already lost that battle. Now, who's ever done 5 minutes? Nobody's done that, right? Well, take a look at this. Right off a brand new 3T scanner, 1, 2, 3, 4, 5 localizers. It's an elbow. We didn't know where it was. It's a knee. It's in the funny position. Whatever it is, it happens. I see 2 commonly. I see 3 not infrequently. And I walked up and watched this live. 5 localizers. That's not the way to go. That does not contribute to diagnosis. That does not contribute to patient care. Unfortunately, and this is a slide from the Hitachi promotional material, you know, the manufacturers are focusing on these issues, okay? They're focusing on the fact that we can't be wasting time in preambles. We can't be wasting time trying to find the anatomy. We can't be wasting time trying to set up exams because it doesn't contribute to patient care and it gives us a less patient-focused examination. As a matter of fact, one of the most important factors that I see right now, that I see all the manufacturers moving to, are these automated scan techniques. When you put the patient in, it recognizes the landmarks using forms of artificial intelligence and machine learning in the best of circumstances, standard formula in the worst, and automatically positioning the slices. So what's the value of that? No 8 localizers. I kind of know where I am, right? Okay, the other benefit is reproducibility. I get the same slices every time. MS patient, tumor patient, comes back every time. And mind you, it's not just the brain. The brain is entry level. Okay, here's some work on one of our exams that, scanners that has a spine automatic scanning protocol. And you can see these are the same machine. On one case, we bought the automatic positioning protocol. On one case, across the same neighborhood, we didn't buy the positioning protocol. And you can see that one of them has a slightly longer exam time, maybe 2 minutes longer. That means over hundreds of exams, they're 2 minutes longer. What does that mean? That could be a cigarette break. That could be a cup of coffee. That could be, you know, a sequence that I can repeat. Those 2 minutes are a major commodity for me, that I can stay focused on the exam and the patient welfare. And we'll talk about how a minute or 2 makes a difference to the patient and how surveys deliver that back to us in a convincing fashion. So you'll see some of that. So, but other ways that we lose time. I walk in there sometimes and I watch the operation and I'm a little bit of a nervous guy and I'm watching the technologist, very nice man, putting a patient on the table and he's talking, he's got a nice little good long conversation going on there before the patient lays down. And part of this long conversation, which can last enough time to send me to grab a scotch, is getting the earplugs set up. You know, the earplugs, they take a while, right? You know, are they set up properly? You know, here you're a caregiver, right? Does it work? Is it occluded? Is the patient too young to really give you validation? Is the patient too old to really get a sense of what's what? It takes a while, right? So that particular preamble, how do I deal with that? Well, we're moving to different systems that don't require that much patient cooperation. I love this system. We put it on all of our high field magnets. You come in, we pop this on the patient's head, and we're in the machine. These are sound occluding, they don't need earplugs, and you're in. And they also facilitate communication. Now, I think these guys have a booth here, and they're good friends of mine, so sorry for the pitch, but we put this on all of our machines. We completely changed the way we equip our equipment because that buys me a couple of minutes. And it doesn't take away from patient care. It doesn't take away from diagnostic information. It doesn't take away from patient care. All right, who struggles with their radiologist in terms of what they want to do in every exam? Anybody? Nobody? Okay, well, we're going to get into them right now, and that's, you know, the protocol optimization, right? What do we do on these exams? What is required on these exams? Okay, really, you know, we're forced to become value-based. What of the 5 or 6 things that I do every time are essential, which ones aren't? When I was at Mount Sinai, we were challenged to make that decision. My role at RadNet is to work with our radiologists and challenge them to make those decisions. And frankly, as we roll these out, this is actually working reasonably well for us. Radiologists are on our side. We all realize that we're patient-focused. We all realize we need to survive, and we all realize there's essential and then there's optional information, and they've managed to reduce the number of sequences for the most part. I think we've all discovered that more is just not better for us. We can't afford to do more, and frankly, the data suggests it isn't better for outcome or diagnosis. So despite the fact that our radiologists are all artists and they all have their way they need to do it, and if we don't do it their way, well, the practice is going to fail. It's simple as that. You know, it's a black and white equation. It isn't quite that way. And when you ask our guys to focus on value and focus on what we need, you can actually see the difference in the bottom line. Now, between March and May, in this particular single facility, we did a few things. We optimized some of the scan sequences, but we also became more value-driven and asked the radiologists to live with what they found was essential. So just for the sake of fairness, although this pointer is not strong enough to go that way, you'll see there's a 30-minute line here. You see, and you'll see the green in this particular slide is diagnostic scan time, okay? The blue and the yellow are things like localizers and preparation time, and the brown is patient handling time, on and off the table. We were able to, you see here, we thought we were 30 minutes. We were 30-minute slots, okay? We weren't. I'm not sure that's ever happened to you, okay? But we were not, clearly not. We're frequently going over, creating a lot of stress and unhappy patients and maybe slots that get canceled. And now, after we optimize, you see we're hovering very nicely at that 30-minute spot. Mind you, there's a little lower on the diagnostic side, but not a ton. Okay, but we didn't necessarily reduce quality. Sometimes we improve quality. Frankly, if I've got 15 minutes to scan and I'm trying to do 8 things and only 6 have value, I spend that same 15 minutes on 4 things that have value, we're going to end up with better quality. And I think we see that across the board. Now, I said, more is not necessarily better. There's data now in almost every corner that a 5-minute brain exam, you're sure you've seen this. This is something that Siemens pushes, but frankly, they did the work at Mass General, and they say 5 minutes is all we need for an acute brain. We're not going to miss anything. Here you see the same approach on the Hitachi Oasis. Really the same types of sequences you'd expect to see. Basically a 5-minute exam time. The difference here is one's been validated against clinical outcome, but it shows the patterns, the things you need to produce to make a difference. I don't need 512 squared. I don't need that extra point. It's just not necessary. It doesn't contribute to outcome, and that's really the key piece here. The Philips folks have shown 5-minute abdomen does a perfectly good job with really no drop-off against diagnosis and outcome. Here's a paper looking at shoulder. I forget where this was presented, but they showed, look, we go ahead and use parallel imaging, we accelerate, we make an exam that's less pretty, right? Who's been told if our exams aren't pretty, we're going to go down in flames, okay? Less pretty. No effect on outcome. And again, patients off the table so fast, they give you the most spectacular ratings, and I'll prove that to you as we go along. Here's one on the knee, 5-minute knee. Turns out it's good enough. Okay? What about breast imaging? Do we need to do that big, elaborate breast protocol, or is there a more abbreviated breast protocol that seems to work? And there's a couple of papers out there that point to the fact that breast imaging can be done with fewer phases, perhaps even without contrast. So, lots of opportunities there. On the other hand, there are administrative responsibilities and frankly, physician supervisory responsibilities that also need to be addressed. And that's about communication, supervision, and training of your technologists, okay? That's a bunch of platitudes. Let's talk about practicality. Here's my scan times. The blue, the horizontal line that you can see is 30 minutes. And you can see that I'm doing pretty well across the board. All these different exam types over multiple months. By the way, in each block, as you go to the right, we've introduced optimizations and cleaning up the mess and becoming more value-driven. But you can see there are some circumstances where we're still percolating a little high. We noticed the foot was a little high, ankle was a little higher than we'd like. The elbow, we probably don't do enough of those. That sample's too small. Even the wrist is a little small. But for the most part, we noticed that foot and ankle were problematic. So I went to the tech, and I looked at the green part of the exam, by the way. Look at the green. It's not any worse on those exams. Look at the green on the foot and ankle. It's not terrible, particularly after we optimized. Look at that. We went from there to there. You can see there's an impact, but still we're struggling. So we looked at the doctor part. Oh, the doctors are killing us in musculoskeletal. Well, no, they're not. They're reasonable in 15 to 18 minutes. So where was the problem? We spoke to the technologists, and they said, look, we're confused. We just don't, on the foot, is it a coronal, is it an axial? The terms are confusing us, it's driving us crazy. We're spending too much time thinking. Here's a guy who knows what that feels like. The other piece on musculoskeletal, and I'm going to tell you, this is the most efficient, most cost-effective, least costly tool you can ever do, is tell your guys exactly what the coverage is supposed to be. The minute you get your guys to concentrate on the coverage, realizing that every slice costs the same, but the value is not the same on every slice, you clean up the process. The doctors stop yelling, the techs stop worrying, they stop overcovering. A technologist who is uncertain will overcover 20%, sometimes in each direction, sometimes on 6 or 7 sequences on a single exam. That is roughly 40% of the exam time with zero value. Communication, supervision, and training makes an enormous difference. This type of thing, we give them manuals. I like it right at the scanner. I'm not big on putting protocols down on a piece of paper. The scanner's got the protocols. But I am big on guiding the guys and taking the stress out of it. You know, there were technologists in the room. You know how stressful it is. Is the doctor going to complain? Did I give him what he wanted? That's over. This is what we want. That's what you get. Phone calls stop. The stress drops. Patient focus. Frankly, I'm customer focused. One of my customers is the technologist. Okay, if I can't get them through the day without enormous stress, I'm going to lose those folks. Okay, they're going to burn out. So I want to stay on time. I want clear communication, and I want less uncertainty. And everybody awake now? All right, so standardization is a huge, huge thing for a big organization. I don't care if you're 3 hospitals or you're a regional, a hospital association, or if you're 310 centers. Standardization is a wonderful thing. You can look at it as standardization will set you free to do this special exam, but when things are standardized, the clinicians love it. They open it up. Here's my sequences. I don't have to worry about where things are. You know, the radiologists who are being pressed to read more and more exams every day, okay, really struggle when they've got a big preamble. Where's my T2? Where's my T1? Why isn't this facility doing what they're supposed to be doing? When they come up in the same way, with the same names across your organization, we're 80% of the private practice of New York, okay, RadNet is. 80% of the private practice in New York City. All of those exams are done the same way. Same names, hopefully the same order. It makes everything more appealing. It gives us the opportunity to do centralized maintenance. Now, we're not there right now, but we work towards it. As a matter of fact, we have a fleet of Oasis scanners that are all centrally maintained. If we find a flaw, if we do an innovation on one of our 16, they all get sent out, all in some form of centralized maintaining. We maintain all of our scanners at all different generations. We try to maintain them centrally, but that can only be done if we're standardized. All of Southern California for RadNet has agreed to scan with the same sequences. That will go a long way in helping us centrally maintain. And frankly, when you standardize, when you reduce variability, one of the biggest effects is reduced callbacks. Who loves callbacks? Okay, who wants to be called back? Nobody. You know, we don't get paid, it's bad public relations, the doctors get upset, not customer focused. We can reduce callbacks, it makes a big difference. Here, you see this little arrow? This is when we introduced a callback program that said, hey, before you call somebody back, let's get somebody else to sign off on this callback. You know, whether if it's a regular radiologist, there's a more senior radiologist. If the more senior radiologist can't adjudicate, it might even bounce up to someone like me as a regional medical director. But the minute we started looking at callbacks, the minute we started to simplify our processes, we were able to reduce our callback rate fairly significantly. That's pretty cool. Now, mind you, most of you know I'm an imaging zealot, and administration is a secondary career for me. So really when I get excited is when we talk about innovations that are made available by our manufacturers and how this makes an enormous difference to our day-to-day work. And really, I've always been passionate about translating technology into value. By the way, here's another one. Who has bought an upgrade and never used it? Okay. Who has bought an upgrade from someone who said, if you buy this, you will go faster. You need more efficiency, buy this new scanner. And who's not delivered that? Come on, honestly. Okay, yeah, I see the heads going, but I'm telling you, it's very hard to not have that happen. But you know, again, if you buy something, I think it's worth integrating. It will boost your standards. You will be that center of excellence. It will improve quality. It will make a difference in diagnosis. It will also allow you to overcome some of the limitations of today's technology and enhance satisfaction amongst your constituents, whether it's a technologist who doesn't have to repeat an exam, whether it's a radiologist who sees the additional value of the exam, or the clinician who realizes, hey, you know, I can get fat pressure when I couldn't get it before. Okay, that kind of thing, it makes a big difference. And ultimately, we're all after growing practice. Now, one of the things that I'm a big believer in is this fat separation technique, which sometimes is called Dixon. And you know, those techniques work really nicely, but one of the things you can do with that, other than getting perfect fat suppression, is you can get a 2-for-1. When do you get 2-for-1? Okay, maybe a Denny's on the Happy Meal special, whatever it is. You know, with a fat suppression technique, you can get a non-fat suppressed and a fat suppressed scan at the same time, with no difference in scan time. So if you're a radiologist, you're scanning with PD and PD fat sat, one scan. Okay, that's pretty cool. Here are some examples right off of the open scanner that we run. This is one scan, this is one scan, and these are two individual scans because the contrast is different. But here you see a PD, really nice detail on that meniscus and that little cartilage defect. PD fat set, one scan, took 4.5 minutes at 1.2 T. Okay, PD fat set, took 4 minutes and 11 seconds at 1.2 T. Add a couple more. This is a 12-minute knee exam on an open magnet. Anybody have open magnet in your territory? You doing 12-minute knees that look like this? You know, probably not. It's hard to do that on low field, but you can do it on a high field system. Here's the same thing, PD fat set. These are both fat set techniques. One scan for the sagittals, one scan for the coronals. I think it makes an enormous difference. Same thing here, meniscal tear. One scan for the sagittals, one scan for the coronals. You know, what can I do with a 40% reduction in scan time? I can be a lot more customer focused. I can be a lot more on time, okay? Or I can do more things, you know, with that time. Same thing in the spine. If you're a fat suppressed spine facility, you can do a T2 with and without fat set. In any radiology group, by the way, there's a lot of division about fat suppression. Okay, some guys may want their T2s fat suppressed. Some guys may know there's a trade-off to that. You do them with Dixon, you give them both the same thing at the same time. Some people do. Technologists in the room, do you ever had a place that needed to do a T1 fat sat and a T1 without fat sat pre-contrast? Okay, that's a lot of time with a very little value. Imagine you can get that done with one shot. Same thing with the post-contrast scans. Imagine that some guys are fighting, they don't like the fat sat, some people do like the fat sat. I love fat sat, the surgeons generally don't. Two for one, it's a beautiful thing, everybody's happy. Can't get that every day, but this is an innovative technique that makes a difference there. Ultimately, what I'm trying to do is shorten the exam experience. We've talked about making it more consistent, but I want shorter exams, okay? Our goal was a couple of years ago to get 90% of our exams under 20 minutes on and off the table, pretty much, and you know, without contrast, and maybe get to about 30 minutes on and off the table with contrast. And you know, we're close in those circumstances across our scanner platforms. Why do I care? Well, we know all the obvious reasons, but this is one of my favorite letters. You know, here's a letter from a woman back early in my tenure, and we were rolling out a lot of the changes here, whether we're optimizing an old machine, or using tools like noise reduction, or using a new machine. But you know, here's this woman who comes back in, and she said, she loved all of us, of course. This was like one of those letters that loved everybody at the front desk. Everybody was so sweet. That's nice. I love that. But here's the part that I liked. I was relieved to be on the new equipment that only took 15 minutes because I began to have a lot of pain in my leg. Patients react to a shorter scan time, okay? If I offer a shorter scan time, patients will come to me. It's really very, very simple. You can almost not imagine how granular that information is and how even a subtle difference of 2 or 3 minutes translates into better patient ratings. You can see where we are kind of across the board. We're doing pretty well. This is way back before we worked on the foot and ankle. So how did I deal with the foot and ankle? We gave them a webinar. Okay, we had a guy go in there and give them a webinar. This is a coronal, this is an axial, this is our coverage, and it just improved the process. We made the effort to educate our team. Here's an interesting little bit of pseudoscience. Here's a wide bore 1.5T against an extremity unit. Now, the extremity unit is really comfortable, right? You're just sitting there. It doesn't make any noise, right? It's not hot, but it's longer, right? Anybody have an O&I unit? It's not a short exam, right? It's a long exam. Certainly longer than a state-of-the-art 1.5T. Let's see how patients react. We asked them about length of scan, comfort of scan, noise of the scan. Notice on the O&I, nobody hates the noise. By the way, the big one is, this big blue one here is just as good as expected. Anything to the right of the blue is a big plus. The patient said, this is much better than expected. Anything to the left of the blue is not really desirable, okay? Worse than expected, much worse than expected. Good news is we don't have a lot of worse than expected on any of these scanners, and we're doing pretty well here, you know, in terms of noise and even comfort here. Notice that we get more positives on comfort, more positives on noise, and more positives on length of scan on the closed bore unit than I get sitting in the thing like this. Why is that? Scans are shorter, okay? 90% of the people said the scans were either as expected or better. 42% said better than expected. Only 20% said better than expected on the longer O&I scan, even though it's much more comfortable. Now, 3T is even faster. Speed is good. Who's skeptical that 3T's faster? There you go. Okay, the good news is I have data. Thank you. Here's the data. Here's our same building, same facilities, same practice. On the left is a 1.5, on the right is a 3T. Same practice, same value-driven architecture, same sequences that we want to run. And you can see here that the diagnostic green bars are just a bit shorter than on the opposite side. Some of this stuff has got too small a sample, but look at what the doctors are doing here. We're just a little bit shorter across the board. So definitively shorter. So that couldn't make a difference, right? Well, here's roughly 500 samples from the same facilities, same schedulers, same technologists, same neighborhood, cranky New Yorkers. Look what we get. Again, looking to the bars to the right of the blue bar. Okay, notice that, by the way, and 3T scanners are louder and they're hotter. They're not comfortable compared to a 1.5. We're getting better patient comfort numbers. Actually, well, not necessarily better patient comfort numbers, about the same statistically significant comfort numbers. I got 53% of the people on the 3T say the exam is shorter than they expected. Okay? 53% say it's shorter than expected. Considering that the exam is actually louder and hotter. So a little bit of speed makes a difference, and patients perceive it. Another way, by the way, to use new techniques to go a little bit faster, anybody ever do a sagittal flare and an axial flare? Happens all the time. You know, the most efficient way to get, once you're going for more than one scan, is to move to a 3D scan. Okay, and we routinely do, you know, this is examples from the OASIS, we routinely do a 3-plane 3D flare instead of doing two 2T scans. So instead of taking 8-9 minutes, I might take 5 minutes. And the benefit is I get the third plane for free, and all the slices are thinner. This is very nicely, widely accepted in our practices. Here you see, again, all three of these flares, all from one acquisition. You can see we're getting, you know, you can see that this is a big boy high field scanner. It does a beautiful job with diffusion. There's a little acute lacunar infarction right here. All the things you'd like to see, but frankly, the innovation here is shifting to 3D. And we have practices that want a sagittal and an axial. In those practices, we go 3D. Other practices, when they do multiple sclerosis, they're going to do 2 planes. In those practices, they use 3D for those planes. So it's a nice thing. In pediatrics, when you want to get that scan over before the patient loses his tolerance, 3D imaging across the board. This is one 3D scan. And again, beautiful diffusion, really beautiful high field quality images, really leaving nothing to be desired. So how else do we get through an exam? Well, repeated scans are killing us, right? You can add all the numbers up, and if you don't say that we're going to repeat scans, you know, you're kind of lying to yourself. So how do I get rid of those repeat scans? Well, part of the reasons we repeat scans because there's motion. And we have techniques for that, and they're becoming even more and more ubiquitous. We repeat scans because of fat suppression failures. These are the major reasons. And now, as you can see, we're moving into these acquisitions, lots of different names for these. Hitachi calls this radar, and there's a radar flare. But frankly, I think of all the manufacturers, Hitachi is at the forefront here in enabling radial acquisitions for every acquisition. Frankly, I didn't even have any idea they could do it for all of these. I just found it out when I put this talk together. Because, you know, we use it for T1, we use it for T2, we use it for flare, we use it in the body, but I had no idea I could do gradients and vascular imaging that way. And, you know, that's something that I'm going to get right on when I get home. But here, we use radar routinely in the pelvis, in areas where, you know, maybe it doesn't offer enough value. It's just the quality is always there. And it just gives us images that are consistent. Here you can see an example of a typical shoulder on the far side up here, you know, with the typical respiratory and somatic motion. And here you see an example done without that motion with the radial acquisition. Many, many facilities have adopted radial acquisitions, particularly for the shoulder. It's sort of the entry-level challenge. Everybody's got motion in the shoulder. If you can make these radial techniques work, the radar work, it just makes you more reproducible. It just does. Here you see a typical dilemma when you fat suppress, particularly when there's metal around, the fat suppression fails, your image becomes completely non-diagnostic. If you can improve the fat suppression around metal, you can see some of the disease that you'd like to see. Okay? And these are these Dixon techniques I showed you about beforehand, these fat and water separation techniques. Aside from the 2-for-1 factor, they give you perfect fat suppression in circumstances that always fail without them. Brachial plexus, soft tissue neck. Okay, some of the spine exams that we do, some of the extremity exams we do, beautifully done with fat suppression. And again, what you're seeing here is a 2-for-1. This is one acquisition, this is another acquisition, this is another acquisition. Fat suppression with and without fat suppression, so you can get the best of both. Here's a T1 post-contrast, all 3 planes. Okay, looks like I have here the non-fat suppressed and the fat suppressed together. Again, because it's free. But all of this was a tease that gets us to the fact that open MR systems are patient-friendly. They're patient-focused. And I've been around open MR for a good long time. And this magazine was brought to my attention just a little while ago. It turned out I wrote an article back in 1998 working on the low field open MR exam scanners we had in those days, 0.2 and 0.3 Tesla, and there was an enormous challenge to getting exams out in those days. Now, mind you, we cared about patients. We offered this type of technology, but the challenges were great, and no one would pretend that you could match the same quality as a high field exam. You know, these types of machines, you know, they were pioneers, they were patient focused, and frankly, you know, we believe in that as an organization, but, you know, they created challenges that few could overcome. Today, you know, we actually have these rolling out throughout our network on a routine basis. It's a 1.2 Tesla magnet. It has the uniformity, the gradient strength that you need to have to do state-of-the-art work. All kinds of cool things in here. You know, I could keep eating breakfast for the next few weeks, and I still probably wouldn't, you know, overcome 660 pounds. It's a wide open system. You know, these are challenging patients, right? These are patients who are just either anxiety driven, or they're heavy, or they're truly claustrophobic. And to get patients in this machine and get a high quality, high field exam is a big deal. Frankly, you know, there's lots of coils. All the coils you'd ever want to have are in there. And for all body sizes, actually, you know, it really is nice because we actually can use a phased array body coil and do all that state-of-the-art high parallel imaging, even in the heaviest of patients, with an innovation which allowed us to take that largest phased array coil and extend it with side extenders so that you can actually even handle patients that you could barely squeeze in with, you know, with a heated gantry and bacon on the outside. It's difficult. Now, here's our patient satisfaction numbers from this particular scanner. And frankly, these are pretty pedestrian patient satisfaction numbers. And frankly, I think that's a big success for us. This is a challenging population, patients who don't want to be in there, and we delivered pretty good numbers. A lot of the big one, again, is the as good as expected with a nice hefty piece on the right-hand side that said this experience was better than expected. Okay, and I think that's really kind of what we're after here. Validation that in this difficult population that we can do well. Can somebody tell me what time it is? Perfect. All right, so for the rest of our time together, we're going to do a little show and tell and just show you the kind of work that we can do. And you can see that this is not your grandmother's open MR scanner. It's just not. This is a high field system that performs high field exams. I used to do MRA on my open magnets under duress, just under duress. And I believe that you saw more false aneurysms than you saw real ones. I mean, it was just borderline. I don't even want to use the word. It was just, you know, borderline is not even the right word. Okay, it was just not acceptable for clinical practice. I have no reservations reading images like these on a routine basis, whether it's vascular imaging in the neck without the use of contrast, delivering very nice high spatial resolution, the kind of things that I expect to be able to make a diagnosis that will deliver the answer clinically on a consistent basis. Now, these, by the way, these come from multiple facilities around our network. I have them all feeding in because when I roll a new scanner out, I validate the image quality. So I'm getting cases coming from the West Coast, from the East Coast, from North, from South. They're all feeding in, and I get to sort of just cherry pick and bring things to show you. But contrast MR angiography, just like you'd expect a high field system to perform. Not particularly special. This is the imaging protocol that rolls out to every RadNet site in the country. Okay, so if all of a sudden I have bad image quality somewhere because something's happened, a mouse has crawled in with a tinfoil lunch or something, you know, I know that my protocols are set and we can go in and see if there's an issue with the system. But this is the kind of work we expect to be able to do. Cardiac work. I wouldn't, you know, I would say that you should be able to knock out a basic cardiac exam without any particular problem. You know, the key thing is again, this is what we used to deal with, right? This was a diffusion scan, and it was a miracle on our open system, right? It was a miracle to be able to do that. You know, this is what we get today. We get images that are high field images. It's really very simple. This patient, I think, is, I don't think there's anything on this. Oh yeah, this patient has an old stroke right here in the left frontal region. But, you know, nothing to be desired. This patient has a traumatic brain injury. These are the sagittal images from a 3D set. Here you can see the bifrontal encephalomalacia. See here, these are all reformatted images. Coronals are reformatted, and you can see what you need to see in one shot. These are real university quality, definitive exams done for patients who cannot tolerate cannot tolerate a traditional system design. There's a macroadenoma. Again, these are routine exams in clinical practice. This is a follow-up resection adenoma. Okay, you got to follow these patients up. The images have got to be definitive. They can't be, I don't know what I'm looking at here. I can't see what I need to see. I have to see what I need to see. Okay, here, this is a very small lesion. See this little bump right there? See that little bump right there? It's a meningioma. I think I was seeing there was a movie star recently that was revealed that she had a meningioma in the frontal and just had surgery. Actually, Sunday, I think one of the news anchors. That's the kind of lesion we're looking at. Now, this is what we used to get. And by the way, the reason why I have these images on the then, because they were from my teaching collection of the best images I've produced. Okay, I am not kidding. This is what I used to put up to impress everybody, how great our images were. Every single then, I promise you that's where it came from. Okay, I didn't go back into the bad archives. I went into my teaching archives. Well, this is what we get today. And take a look at those scan times. Can you do better than that? Sure, knock yourself out. But look at those scan times. 2 minutes, 2 minutes, 2 minutes, 2 minutes. Maybe another 7 minutes. Cervical spine with 1, 2, 3, 4, 6 sequences. That's what we expect. Again, this used to be, I put this in a magazine. It's probably in that magazine article. Okay, this is the kind of work we get today. It looks like a high field scanner. Here's a patient with an ependymoma. You know, there's nothing to apologize for. The surgeons don't say, hey, get me a real scan. They say, thank you very much. I have the information that I need. Here's a patient with myeloma. So, you know, these aren't, you know, we're dealing with sick patients. We're dealing with people who need an answer, and we're able to deliver that consistently with this technology. This patient has arachnoiditis. For those of you who like to look at images, you see we're all clumped up in here. You see how it gets kind of congested in here? And the nerve roots are all peripherally distributed. They really should be sort of floating in there. That's an example of arachnoiditis. Thoracic spines, again, not a particular challenge on these machines. I think the ultimate statement on these machines is, can you deliver abdominal imaging that works? Do I have the techniques that I need that work every time, every case? Dynamic multi-phase abdomen, diffusion imaging, adequate fat suppression, excellent fields of view, in and out of phase imaging, and it's all here. You know, all the usual suspects are right here on the screen. That's a FAT-SAT T2. That's a balanced steady state free precession. That's a single shot fast-band echo, in and out of phase gradient echo. This is the kind of stuff you'd expect to see. Pre-contrast, arterial, hepatic, delayed. Just what you'd expect to see. How about diffusion? I mean, real diagnostic diffusion, ADC values, you know, the ability to use multiple B values and get your ADC values, just like you'd expect. Again, in and out of phase, fatty liver, very important to be able to detect. Okay, pre-contrast, post-contrast, really nice to see. Here's a patient with a number of renal lesions, hydrocephalus, hydronephrosis. Neuroradiologist sort of a little out of control here, multiple phases. Here you see the other images. Again, you know, the kind of things you'd expect, and diffusion imaging. Okay, so we can characterize that lesion, you know, by ADC, by T2, and multiple B diffusion. MRCPs. This was our first one. This is the kind of thing we see every day. If the lights, I could tell you if the lights were down, you'd see all of these individual stones in here. Actually, you know, never mind. You can see again, look at how beautiful the pelvic imaging is. This is all done with radar. Okay, the typical things you'd expect to see: adequate fat suppression, and the optimal fat suppression, frankly, pre-contrast, post-contrast, small field of view imaging with radar, you know, again, fat suppressed post-contrast imaging, just as you'd expect to be able to do. High field style, abdominal and pelvic imaging. and the diffusion there at the very top. Again, just, the kind of things, we do these cases on the machine. In reality, at many RadNet sites, if not all, we kind of just take all comers on these machines, okay? And we don't bother to, we just kind of schedule it. When I was in New Jersey, we had a special number for open. If you wanted to go on that 0.2 open and you called that special number, we put you on that machine if there wasn't medically contraindicated. We never wanted to be in that discussion with a patient saying, well, it'd be better if you, that was entirely too lame for us. If the patient wanted it, we provided it. Now we really just happy to provide this for all of our patients. And we have facilities that will have only this scanner. Even prostate. Now, mind you, I would think the standard of care for prostate is probably a 3T scanner, okay, with sophisticated diffusion techniques and dynamic contrast enhanced imaging, but sometimes patients won't go on the 3T scanner. And I'm pretty confident that we can issue what we need, a quality ADC value, multiple diffusion weightings, and a quality T2 that can be used to fill the PIRADS criteria. Again, there's the diffusion we see on top, higher and higher B values. Again, really quite nice. Now, this happens to be a very small woman. Unfortunately, it's the only example that I had that I could pull from, but typical multi-phase breast imaging. It works just as you'd expect, and frankly, I would not hesitate to do breast imaging on this particular machine. Segueing into musculoskeletal, here you see somebody with a sacroiliitis. Notice the adequate fat suppression, the high spatial resolution, the consistent quality across the board. There's my pathology right there. Again, the ability to deliver this. Again, teaching case, showcase, RSNA case. Okay, this is what we do today, and look at those scan times. So again, I think the reason why this works is because the technology has changed. It's not just the field strength. It's the ability to move the patient to isocenter. It's the ability to do shimming that it does so the fat suppression doesn't fail. You can pretend things work and then it will fail, but if you have these technologies that actually prevent the failures, you stay on schedule, you stay patient focused, and the patients walk off in a comfortable fashion. Here again, you can see the typically really robust fat suppression we're getting on the system with excellent coils. And really, I think it's not as so much the field strength as it is some of the technical optimizations that we can get to get better and better fat suppression and make it more consistent across the board. As you know, our contrast resolution, our ability to detect pathology in musculoskeletal is almost entirely dependent on our ability to suppress the signal from fat. It is the most critical thing. Okay, when we used to work at 0.2T, we do very low spatial, but we maintained our contrast resolution and maintained our ability to make a diagnosis by getting the fat suppression properly done and getting your contrast. Now, we did a lot of that with stir because we didn't have these techniques on the open magnets. Now we can do the same techniques we can on all of our high field magnets. Again, adding to that consistency and that reproducibility and standardization that I'm dying for. Elbows, these are going to be tough to do. Perfect fat suppression. Again, knees. With that fat mortar separation, we get excellent fat suppression. I think the image quality really leaves nothing to be desired. I mean, I have no problem. Again, I just love the fact that I get 2 for 1 on these. I just love the ability to make a definitive diagnosis, see cartilage lesions definitively. I mean, look at the cartilage lesion. Look at how you can see that subtle irregularity, that little fissure right there. This is not your grandma's open magnet. Okay, this is grandma's open magnet. Again, this is my show image, but this is what we get today. We get gorgeous, typical high field exams. These aren't show images. These are the day-to-day cases that I pull off my systems. When I vet, this patient's got a little Achilles tendinopathy. You can see just a little signal in that Achilles tendon. This is a patient with a stress fracture of the talus. Again, notice how consistent the fat suppression is, how consistent the quality is. These are 30-minute exams, on and off the table in 30 minutes. Open magnet, on and off the table, 30 minutes. The scan times that you will see here run somewhere in the vicinity of 15 minutes. Okay, this is what we're after. What does that say, 30-minute reminder? Here you see a calcaneal fracture. Here you see hip exam. The kind of things that, they're challenging, even on high field systems. It can be done really quite nicely on these open design high field systems. Again, just the typical, here's an arthrogram, T1 fat sat, long bone study, a lot of things to look at. And, just running through images really is just designed to build a comfort level. But you see what we're after, okay? And you see how it all ties back to a more comfortable patient experience. You see how it all ties back to being value-driven enough so that we can stay in business in this environment and provide this type of imaging for our patients. It's a difficult financial environment, but it's also an environment where patients are more demanding. My colleague said to me once, patients used to sit on the table for an hour and a half and not complain. Why are you obsessed with 3 minutes? Because patients no longer will tolerate that, okay? They just know. They know the expectations are they should be able to come in, be comfortable, not get stressed, and get out. And that's really what we're after here. And I hope I've given you a reasonable sense of how we leverage this technology to achieve what we're all after, no matter what technology we're using, and that is, being patient-centric. Thank you for your attention. Do we have time for questions? You 10-minute reminder. What is it? Do I actually still have 10 minutes? Okay, any questions for me? Yes, go ahead, please.
So do you have these radiologists who tell you that you're killing people or that you're endangering their professional license?
Maybe if we could use the mic so everybody can hear your question.
I'll repeat your question, but yeah, please come to the mic otherwise. So we had, the provocative question that I alluded to earlier. Do we get feedback from radiologists saying, you're killing my patients, you're destroying my ability to do practice? Yeah, there is always a little bit of pushback. So one of the reasons we don't legislate for our doctors, but we partner with our doctors, is to say, look, we need to be more value-driven. Meet with your colleagues. The MS, mind you, we're a huge number of radiologists in New York. We're a huge number of radiologists in California. Decide for yourselves what the value-driven set is. We urge them that, it's pretty much got to make 15 minutes, but that 15 minutes is yours, okay? And you can see 15 minutes is not a huge challenge. And, under those circumstances, we do pretty well. On the other hand, there's a lot of personalities in the group. And even though the group may have agreed, this is what we do, we still have people, and I'm actually going to see somebody today in this exact situation, right after this, right out to Santa Ana, okay, they're chafing under the group's recommendations. So I think we got to go back and maybe revisit this. These are not written in stone, but my whole point with the artists, everybody thinks that they're artists, the data says otherwise. The data says 5-minute brain is not going to miss anything. The data says the 5-minute knee is not going to miss anything. The data says this 5-minute shoulder is not going to miss anything, okay? So if I give you 15 minutes, we're dancing in the streets, okay? It really shouldn't be that hard. Now, philosophically, it comes down to, in today's era, I think we can do less of the just-in-case scanning. There was that one time, we did a brain, but, we saw something else, and gee, I always like to throw this extra thing in. Not anymore. Okay, that part we have to bite the bullet. But we're not giving up. We don't want to give up quality. We don't want to affect outcome. And frankly, I think with the times we have today, based on the literature that keeps coming out from academic centers and private centers, that we're going to do fine. But yeah, it's a challenge, as you might imagine. If I said otherwise, you'd think I was crazy. Other questions? Nobody? Yeah. Please, would you mind coming to the mic? Or you can just, if you can't make it, just tell me and I'll repeat it.
How much do you use smoothing algorithms on a lot of those protocols you showed?
Do I use smoothing algorithms? Anybody do CT in here? Anybody do CT? Everybody familiar with iterative reconstruction? What happens with iterative reconstruction? You use iterative reconstruction, a clever reconstruction method that removes noise from the image, allows you to reduce your radiation dose by 50, 60%. Gold standard quality, 50, 60%. Okay. You see where I'm going here. I use noise reduction algorithms on every magnet I run, from 3T through 1.5 through 1.2. Noise reduction algorithms are an essential tool. Okay, just like I'm not going to give my patient double the radiation to avoid using iterative reconstruction, I am not going to give my patient double the scan time and an uncomfortable patient experience and a loss of diagnostic information that I can't provide now because I'm scanning twice as long without noise reduction. I believe in noise reduction. The algorithms are spectacular on modern scanners, and I think they're essential. As a matter of fact, if you ask me, thank you for bringing that up, you ask me and you're not using these, and by the way, you're probably not. I would suggest that the best way for you to spruce up your quality and your efficiency is to get to using these right away. I use them on every single thing. I walk into an old machine, I may be doing that today. As a matter of fact, I fully expect to be being there today, and with unhappy doctors about image quality, that's because things have drifted downward, and sometimes all I have to do is go in and apply the appropriate noise reduction. All of last week, I was taking these images that they thought were good, that had that look that radiologists like, that grainy, high-resolution look. Radiologists love noise, okay? It's been shown in CT, actually. You can take an image that has no noise, and the radiologist says it's too smooth, and then we throw the noise in, and they say, oh, I love that image. Okay, well, it's all artificial noise we're throwing in. MR radiologists feel the same way. But we pulled that graininess out, and all of a sudden, the image has more appeal. You get rid of that background noise and subtle pathology comes out. So, short answer, and you clearly step right in my area of sensitivity. I am a strong believer in noise reduction techniques and actively encourage you to use them 100% of the time. They really work well. They can be totally in line. They create no workflow challenges whatsoever. And I guarantee that customer satisfaction, and all of my customers, we talked about them, is much, much higher if you use that. Yes, yeah, come up, please, and then go ahead. I'll take your question while he's coming up. This will be the last two.
Spatial resolution, do you follow the ACR recommendation?
The mic's working here. I think that was your answer. Go ahead, go ahead.
So I'm wondering if you have an IB sedate business, and has this technology impacted that?
You know, I don't have an IV sedation business much in our RadNet that I know about. Frankly, I would have no hesitation at sedating a patient, putting him in there, but my goal for these machines is to help me avoid sedation. Once I sedate the patient, I've got any scanner to use. But I don't have a problem with that, and there is a state where, you know, this would give you that extra advantage. Okay, so I'm going to give you an answer to your question. I don't feel obliged to meet the ACR criteria precisely unless I'm submitting to ACR, okay? It's as simple as that. Do I feel like I'm cutting corners? No, I feel like I'm doing things in a more clever, more patient-focused, more diagnostic-driven way. That's a committee, frankly. You know, and I think I use them as a guideline. I certainly am approaching quality with a great zeal, as you've seen here, and consistency, but you know, just like I consider the ACR rules as guidelines, just like we did with screening with MR contrast, and as you see, that's an evolving process. Just as you'll see now over the next year or so, screening before CT contrast is going to change. These are guidelines, but the criteria that I use is the ones that satisfy my radiologists and my referring clinicians, that are as patient-focused as possible. I don't think, I mean, you've seen, these are very, very representative of what we do. I don't think we have anything to be apologizing for. As a matter of fact, I think I'm thrilled. And I feel very comfortable with these images. Okay, I have time for your question. Where are you? Last one.
Do you have a patient flow coordinator assist the tech with those scan times you presented, or does the tech do the prep?
So you said you presented those scan times, and you asked me, do I have like an aid? Is that the question? Yeah. We don't have aids at all of our facilities. We have them and we use them. I'm a big believer in aids, but you know, as I was telling you, that I was allotting almost 10 minutes of patient handling at the New York facilities. 5 minutes on, 5 minutes off. In Edison, when I achieved those numbers, I had, I think, 3 aids, and we had a table turnover time of 2.5 minutes total. Okay, it was a wonderful thing to see, where someone went into the room and ushered the patient back, another person went into the room simultaneously and changed the tabletop. In those days, we had to enter the patient by hand into the machine. Back in 1995, we had really slow, you know, it was a very slow process, but for the patient, it was very concierged. For us, it was an assembly line, and we went right back in. And 2.5 minutes later, the machine was clicking again. When we knew that the scan was about to end, everybody in the facility knew the scan was about to end, and they were standing by. Patients were always standing by for the machine. Patients were always, staff was always ready to get them off. But in New York, we don't have that. I haven't been able to make that kind of a change yet. So we really do, in real reality, have about 5 minutes preamble and about 5 minutes transition on every single exam. So I've only got 15 minutes. If I can get down to 2.5 minutes, I can increase 2 things. I can increase the value of that exam, do scan more, increase the value of the exam, get the patient off faster, survive when the government continues to come down upon us over the next couple of years. You know, let's just say if there are folks in the room who are skeptical, we can't do that, we don't have to do that, it's bad for, you know, we're going to be out of business. You'll be out of business. It won't be an argument next year. You know, we will not be able to stay in business at 45-minute, hour-long exam slots. It's not going to happen. So, you know, this is, you know, in the end, this is a practical approach. Not the only one, but it's a practical approach to patient focus and survival. I'm sorry, I don't speak English. You know, Spanish is my primary language. I think that says, okay. Thank you very much for your attention.